I wanted to create a safe space to have uncomfortable yet transformative conversations that move people, amplifying the voices of those who are underrepresented and who inspire positive change. I'm Toni Williams, and this is Brooklyn Savvy. Welcome to Brooklyn Savvy, where we engage in meaningful conversations to foster deeper understanding and connection. And I am so pleased to be joined with Lurie Daniel Favors. Now, you are the executive director of the Center of Law and Social Justice. When I see you in the flesh, I almost want to hug you because you know you've got a lot going on. Thank you so much for all that you're doing and all that you are surfacing in this moment. You are a warrior, you are a soldier, and I'm just so glad that you have taken the time to participate in this.
I'm just grateful for the opportunity to sit in this space and these dialogues. They matter so much, and so thank you for including my voice in this moment.
Certainly. And to Dr. Torian Easterling, so wonderful to have you. We're just delighted that you're going to talk to us about health disparities and inequities. Again, it seems as though this past season, we've been talking a lot about structural oppression, you know, and how it impacts every single aspect of our lives. So could you talk to us about health disparities and inequities? And I just want to give you an example. I was speaking to a girlfriend of mine. Now, she's 84 years old. So I talked about health disparities. She didn't quite understand because she's like, well, my girlfriends, and she's a black woman, are all of a certain age. But I said, but it's the social determinants of health that you've been able to evade. Could you talk to us about all of that? Because I'm glad that she's living to a ripe old age.
Absolutely.
Because it's not genetic. The social determinants of health have a lot to do with that.
Sure. Well, first, let me just say thank you so much for inviting me to sit at this round table, share a few things that I know, but really to learn and just to be in dialogue with you both. I think these conversations are really important in this moment. You know, we need to continue to have these conversations outside of these four walls and really activate our community.
I like that, activate our community.
We have to. To the example that you mentioned, when you think about healthcare disparities and healthcare inequities, one data point that you can say, think about life expectancy.
Right.
You have neighborhoods, so places where you live. The average person is living to 82, 85 years old. We're in Fort Greene, Brooklyn right now. So only a couple miles away, Brownsville, Brooklyn, the life expectancy is 72 years of age. Wow. And there are a number of reasons. You can think about median household income, social determinants of health, so housing quality contributes to why we see lower life expectancy.
And access to healthy foods.
Absolutely, yeah, absolutely. Social determinants of health.
Right.
Food, housing, transportation, you name it. You know, these are the non-medical factors that are leading to why we're seeing lower life expectancy. But it's not just how long you live, it's the quality in the way in which you live to that ripe old age, right? And so we want quality of life, and then we also want life expectancy. And so the term there is lifespan. But I wanted to just sort of illustrate why healthcare disparities, how they show up, right? And so when we talk about healthcare disparities, we're just talking about the differences. And so life expectancy, maternal mortality, diabetes, hypertension between groups. So you can sort of think about it from the way you live, age, race, gender. But healthcare disparities, healthcare inequities, is something different. We're saying that the factors are unjust and avoidable. Something that is leading to why we see differences for Black and brown communities across this country, in this city, is because there is something deeply, deeply wrong with the way in which we are delivering services, providing safety net services for individuals, and ensuring access to that care. And that's something that we have to call out.
If I'm learning about social determinants of health for the first time, can you tease out a bit more, what does where I live, like my physical access to housing, whether it's a brownstone, an apartment, a basement apartment, a project building, how does that impact my health care? I'm clear on how access to food, if I'm living in a community that's got vibrant, robust supermarkets, I'll have access to a wider variety of healthy and fresh food and vegetables. But if I'm living next to a location where there's only a bodega, a corner store for my food needs, you know that the trucks that delivered the produce to the bodega, it was the last stop. The food,
because it's rotten before
it's molded.
It's
There's
not good. I've had that. Yes,
it's distasteful. I understand how that might impact my access to healthcare, but you mentioned a couple of other factors that if I'm learning about social determinants of health for the first time, I might not be aware of my housing,
Sure.
Access to transportation.
Right.
I've even heard of voting as being one of the social
Really?
determinants of health.
Voting?
Yeah,
Oh my
yeah.
goodness.
Yeah.
Can you delve into that just a little bit more?
Sure. That's the term that was coined by Daniel Dawes, the dean of the Meharry Global Health Center, and so he calls it political determinants of health. So civic engagement, voting, sort of the decisions that your elected officials make around health. Those are political determinants of health. Social determinants of health are also these non-medical factors that contribute to and influence the outcomes of someone's health. We mentioned housing and transportation, food access, housing quality, education is also in that list as well, right? In New York City, we know that we look at absenteeism sort of as an indicator for our kids, not just because, we're sort of thinking about who's showing up to school or not, but we're also thinking about what are the reasons why
what's
our
the
kids,
home life like?
exactly, why are kids
Where's the
not
lack of
showing up?
supervision?
We
What's
know
going
that in communities like Brownsville, communities like Bedford-Stuyvesant, where we are seeing absenteeism rates higher than other neighborhoods, is oftentimes because of respiratory issues. We see higher rates of asthma in those same neighborhoods that lead to absenteeism. And so education and health are deeply connected, and also housing, because those are the same neighborhoods where we also see higher cases of mold, roaches, rats, which leads to
The
respiratory
asthma.
illness. Exactly,
Wow.
right. In the Bronx, when you think about the Cross Bronx Expressway, have the highest rates of asthma, particularly because of the Cross Bronx Expressway.
Right, the fumes,
And
the air pollution, right.
And that's
So
social
that's
determinants of health.
environments,
Right.
environmental. Oh my
Social
gosh.
determinants of
Yeah.
health.
And
so
then maybe
all
perhaps
these-
living in a project that's right near the highway.
Absolutely.
Robert
And these
Moses,
all
thank you.
And Robert Moses. All influence our health outcomes, whether you spend 30 minutes working out, whether you're going to eat healthy, you need to do those things. But we also need to ensure that we're advocating to our legislators, to our public health leaders, to do the right thing, to invest in our communities and ensure that we are investing in the
Do
right
you
way.
think COVID influenced some of this life expectancy? How did that change? Because so many of our Black people died during COVID in New York City.
I'm just going to be straightforward. We haven't learned our lessons from one of the worst pandemics in our generation. There was a lot of great work that happened, right, during those 5 years. But we certainly haven't seen the right investments in our public health infrastructure. Actually, we've seen disinvestment.
Right.
We're definitely in this bus cycle where we're taking funding away from our public health infrastructure. COVID highlighted a lot of the inequities in our healthcare system and our public health infrastructure as well. And now we're seeing a lot of the rollbacks of how we're ensuring vaccinations. Data is being shared. I mean, we're seeing what's happening with the federal government where they're taking information off of CDC's website. They're no longer putting data out about influenza activity.
Project 2025. It all
Absolutely.
goes back to
It all
Project
goes back.
2025.
Right.
That's what they said they were going to do.
And so our critical public health infrastructure is under attack. Vaccinations, and we know the misinformation, the disinformation that this HHS director has said about vaccines. We also know that there's going to be, we're challenging and taking away reproductive health services for families. So all of these things are the areas in which we have to hold the line. And where do we hold the line? We have to keep and invest locally. We have to ensure that our state legislators are going to fill the gap where the federal government takes away that funding.
It seems like our health outcomes are worse than anybody, though. What level of responsibility do we have, or do we have, to advocate for ourselves and to make a difference here?
Yeah.
Because it's our health.
Yeah.
And if no one's going to do it for us, we have to do it for ourselves, meaning to advocate with, yes. Could you speak to that?
Yeah.
And that's not to say that structural oppression is not a real thing, but that's not going to change anytime soon.
Yeah.
Right?
Make it worse.
Right,
Yeah.
right,
It's
right.
going to get
So
worse. I also still like to have this context that there has never been a point in this history where Black folks' health has been better than any other racial group, right? We have always had these healthcare disparities and healthcare inequities, and so we have to do more to ensure that resources are brought into our communities, that we are advocating for healthcare systems to make sure they're supporting community health priority and investments.
What does advocating look like when you say that?
I think that there has to be, more coalition building with non-healthcare institutions.
With non-healthcare.
Non-healthcare.
Say more.
So we got to think about the traditional healthcare partners, hospitals, public health departments. But we know that, our legal advocates are doing more around public health. We know that housing advocates are doing more around public health. Social service organizations are doing more around health. How do we bring them more to the table? And then also give them the funding that they need to deliver their services. We have not seen the proper investment in those organizations. We also need to work closely with our legal advocates because we know that healthcare is going to be under attack.
That's right.
Right now, they are considering disinvesting in Medicaid.
Yeah, I think there's a House
House
vote right
bill,
now
appropriations,
to
exactly.
defund healthcare. Yeah.
Millions
And that's
of
not just
dollars
affecting black people, that's affecting people in rural America as
everywhere.
well.
Millions of people are about to lose Medicaid. And what we have seen...
And hospitals.
And hospitals as
Right,
well, right?
yeah.
So think about safety net hospitals that are here in Brooklyn, all across this city, who rely on Medicaid dollars, Medicare dollars. They're going to lose that funding.
It's so short-sighted, though, because if you don't have a healthy population, there's a huge cost to that. I don't understand the thinking.
And it's just not about Medicaid recipients,
Right.
because even for commercial insured patients, the point is that we shouldn't just think, well, I don't have Medicaid, then I don't have to worry about it. No,
Right.
you do.
That's
Right,
right.
Because the stress and the tax on the health system
Yes.
is going to really impact all of our access to health care.
Right.
Can we talk about structural inequities for just a moment? Because I recently had an opportunity to speak with a professor by the name of Dr. John Chenault, who has a phenomenally history-based appreciation for the way in which healthcare has been manipulated, like every other public good in this society.
Right.
And he talks about the fact that at one point in time, HBCUs, we had, I believe he said 14 medical schools that were accepting black students, graduating black doctors, but there was a report put out by the Carnegie Mellon Foundation, and as a result of that report, there was a proactive effort to shut those schools down. Had those schools been allowed to proliferate and to continue to provide black doctors, we would have had tens of thousands more black doctors available to help us navigate the COVID pandemic.
Wow, that's a hard fact.
Yes, and the choice to divest from the social services, from the infrastructure that can provide for that type of pipeline.
That's right.
But these are policy choices.
Absolutely.
And these are policy choices made by the same folks who back during enslavement were deciding that, it's okay to experiment on unanesthetized black women who are owned as part of enslavement.
Well, they thought we didn't have the same pain threshold.
And we saw recently, just a few years ago, a report came out that white medical students still believe, 40% of medical students still believe that our nerves are different than white nerves, and that race makes a biological difference sufficient enough that it's okay to give a black child a generic treatment when you're going to give a white child a brand name treatment. It's okay to allow a black person to sit in an emergency room because we're not going to feel the same amount of pain. These are the results of decisions, policy decisions that were made, investment and divestment decisions that have been made. Talk to us about what advocacy looks like in a moment where they are disrupting healthcare access for everybody. Rural America cannot get access to a hospital, cannot get access to an OBGYN. Healthcare centers are being shut down. And it's just now that people are beginning to realize, when I was voting or I was engaging electorally, and I thought the harm was going to be against somebody else, the harm is now at my front door.
Well, it's the same folks that voted against the Affordable Care Act. It's the same thing that's going on.
But they voted against
the
Obamacare,
Obamacare.
but they
That's
love
what I
their
mean.
Affordable Care Act.
Exactly.
ACA is okay.
And it was the same
Same thing.
Yeah.
Oh, right. For the people who
Same
don't know,
thing. Right, same
Obamacare
thing.
is the
It's
Affordable
yes,
Care Act.
yes.
That's it.
Yeah.
I'm so happy you brought this up, right? The Flexner report.
That's what it was, yes.
Did not only close medical schools, it closed the only black serving hospitals
My God.
that were available at that time in the early 1900s.
And this is at a time where white serving hospitals were not allowing,
We're not
black
allowing
people
us
in.
at all, or allowing black physicians to even practice.
Wow.
So the Freedmen's Hospital, which was on Howard University's campus, there was also a Freedmen's Hospital in Tennessee that was only serving black patients.
Wow.
And so they removed all of those hospitals. They shut down majority of those medical schools, leaving 4, right? The 4 that remain right now. So Howard, Morehouse School of Medicine, Meharry. We're witnessing what these policies have impacted right now today in 2025. We should have had 30 to 40,000 more black physicians already trained and available to communities across this country.
We're in a moment right now, and it feels like, as you said, this season has sort of been looking at the structural disintegration of these policies that we have relied on for the past 60 years. And I happened to read Dr. Uche Blackstock's book,
Oh,
Legacy.
yes,
Phenomenal
yes.
book.
Yeah.
And she had come to Medgar Evers College recently to do a talk, and it was a room full of medical people. I might have been the only lawyer in the room. Clearly out of my element, because I went to law school because I couldn't hack it as a science person. And we're having this conversation, and I happened to get the mic to ask a question. It was the last question, which is always bad because sometimes I can be a Debbie Downer. And my question was, they were talking about pipelines and mentoring, and I said, guys, I don't know if you're aware, but they're destroying all of this. The approach to dismantle diversity, equity, and inclusion programs. Squarely in medical schools, we saw that medical curriculums were one of the first to be attacked when it came to dismantling these sorts of policies. At a certain point, to invoke the great Maya Angelou, when people show you who they are, we must begin believing them.
Right.
At a certain point, having seen this proactive, centuries-long effort to dismantle our ability to care for ourselves within the confines of the broader American healthcare system, at what point do we, as community, have an obligation to say,
ourselves.
we are going to have to create a parallel system of healthcare with all the challenges, all the difficulty, and I know there are many, but we created math and science. I feel like we have it within us to do this. But at what point is it our obligation to then say, we need a parallel system that can exist wholly independent, as difficult as that is, and not just
we
with
had
healthcare.
that kind of in the segregated South in some respects.
Well, until they closed the schools and the hospitals.
Because I was born in the Red Cross Hospital, which was segregated, in Kentucky.
Yeah. Well, I'm a fan of the show, and I know you all are history buffs. But I'll just say that we have to look back at our history.
Yes, we
because
do.
we've had systems. We've had doulas. We've had midwives. We've had community health
who
workers.
were better than the OBGYNs.
Way better. And so what did they do? They took those midwives and they hired them in the hospitals. They required them to have certifications. And now a majority of midwives across this country are white, right? When that role was squarely in our community, AKAs, sorority organizations, started their own midwife cohort, their own workforce in the South. We've done this. We know what we need to do. We even did this during COVID. I mean, families would create cells and networks to ensure that they were communicating and sharing messaging and getting testing and ensuring people knew where they go get their vaccines. The vaccines were a hot commodity in communities. So it was like, okay, I'm going to sign you up. And I witnessed it directly. People were signing their family members up for vaccines across the city. So we know how to do this. We just got to get back to our essence.
We know the strategy. So where's the leadership to make sure that this happens? And is it happening locally here in Brooklyn and other urban communities as well?
Yeah, the leadership is always there. I think it's really, how do we get critical mass out? Folks are having conversations. You talk about, our local NAACP.
Right.
There are coalitions focused around healthcare. I've been part of a coalition because the state was planning to close SUNY Downstate.
That's right.
Yeah.
And we started to rally behind to say, all right, what can we do? We want to raise our voice, but we want to do it in a very informed way. So we want something different. That means that the community will have to be involved in shaping the future of this hospital. There'll be additional public hearings, but those are the opportunities that community can come out and really shape the future for healthcare, certainly in their community.
What role is technology playing in any of this? And I'm asking it for a number of reasons because, in talking, now I'm going to get personal, in talking to my doctor, and, there are formulas now. Some of the social determinants of health are not issues for me. But does that change anything for me because I am African American?
Right. Yeah.
If you could respond to that. I know it's kind of personal, but I'd like to know. It's like, you want to make sure that you're getting the right information, that you're giving the doctor the right information, and that your formula is going to be right, that the algorithm is going to be right.
Yeah. I mean, algorithms are important. Let me just say, on one hand, there are some good sides to it, right? We need technology. It allows us to share more information. It increases access for people that have.
I like the medical records and stuff.
I was about to say
and
that.
I like the my charts. I love
my
charts.
charts.
I love my charts.
Democratization of data.
Right.
This is your data, right? Why does the hospital own your data, right? We need to democratize data. We need to make sure that individuals have access to their own data, and technology allows that. It also allows individuals, if they're not mobile, to access a provider much easier instead of someone coming into the home. There are pluses.
Yes, that virtual is quite nifty.
Well, there's a there's a proposal now legislatively to end access to telehealth.
Absolutely, yes.
To me, that's so absurd. I mean, how easy is it? That can't be expensive.
Well,
I mean, what you know?
yeah, they don't want everyone to have health care, right? And so in order to do that, they have
you're
to...
thinking as a kind person who's concerned about humanity.
Right. Yeah.
You have to replace that with a brain that says, I only care about the dollar in order to understand what's motivating these folks. Because the people who are doing these sorts of things, they don't care about humanity the way that you do.
Absolutely.
And that's why we're in the situation now.
You're absolutely correct.
Yeah.
But I'll also say that there are outdated algorithms, and this is where technology can be, a negative and really be a problem, right? So we have algorithms right now that says, and we were talking about implicit bias in healthcare. So there are algorithms right now that says that Black people will not have access to kidney transplant, right? So because of what they think that there is increased muscle thickness in your kidney that allows transfer of fluid to happen slower in Black kidneys versus white kidneys. And as a result of that, then kidney transplant access we see a disparity across this country. And so there's been work to remove that race-based clinical algorithm.
That's not medically sound or scientifically sound. That's just something someone programmed into
the
right.
into clinical decision making.
It makes you feel like we're really on an uphill.
Even on the reproductive health side, there is a VBAC calculator, and in that VBAC calculator, they use race to make clinical decisions. And so now there's work to remove that race-based clinical algorithm for vaginal birth after C-section.
Wow.
Right? And so when Black women are telling you they're not giving me the access to do vaginal birth after I've had one C-section, this is why. Because they use clinical decision algorithms based on race to deny access to services.
And to be clear, algorithms are generated by people. And so if I am a part of a community that has held on to the mythology that Black people don't have the same or have a thicker skin, literally a thicker skin.
Absolutely.
As we were having conversations about the physical prowess of Black people such that we othered them. Then if I go to medical school, there's no course I'm taking in medical school. Correct me if I'm wrong. Again, I had to go to law school because I couldn't hack it as a doctor. There's no course in medical school that will cause me to disrupt that way of thinking. So I'm bringing the biases that I have cultivated from my background, my community, my heritage, my culture, and I am infusing them into my medical practice. So when I see you show up with a kidney issue, I'm going to think, oh, well, he's Black. His kidneys are super kidneys. They don't need this transplant. I'm going to give it to this white patient who I think might need it more. And I think that white patient needs it more, and you need it less because of the racism and the inherent bias that I am bringing to this space. And so when I'm programming the algorithms to come up with these formulas, and I have that sort of baggage with me, of course the algorithms are going to reflect my inherent bias. It's not accidental. These are choices people are making. And am I...
That's absolutely right. But even so, if you add that calculator into technology, then it just automates. And so you're saying that the doctor's saying, all right, Black, and then I'm looking at your labs and I'm seeing your tests, and then the technology computes the number, and we'll say, all right, that person doesn't get kidney transplant.
This is
right?
really, this
so
is
you
really
take the
deep.
human factor out of it.
Yes.
Right?
Yes.
And so how do we have to remove that calculator
We
altogether?
got automated racism. Lord have mercy. Lord have mercy.
That's a whole field that we need to think about when we think about AI. We need to think about health equity in AI. What is that intersection as well?
So what do we do as the individual that is speaking, has that one-on-one relationship with the doctor? You know, I'll tell you what I do. You know, I tend to do a little research. You know, I'll Google certain things. It might be right, it might be wrong. Maybe my doctor's tired of me trying to self-diagnose. I barely have words for how helpless one could feel in a situation like this.
And then add a
I don't
power
like
dynamic.
That. Right. The power dynamic of, well, this is what they're saying and this must be what it is. We have to fight for what we want. And you have to deal with your doctor that way. Or what about Black doctors? And, you know, I mean, isn't there a website now called Find a Black Doctor?
Yeah.
All right, maybe is that the solution?
And is being a Black doctor sufficient?
Yeah,
because,
right.
Because I know in the education space, in the legal space, if I am a Black person who others myself and thinks downward about my own community, I'm going to carry that bias into the courtroom as well. So
very much internalized.
Yes.
We got to unpack all of it. Racism affects us all. Absolutely. Yeah. Well, let me talk more about, sort of the personal patient,
Right.
because I do think that's really important. We need to be more educated about our own bodies.
Exactly.
But I think the first thing is that we need to sort of figure out what are we comfortable doing before we even go to the doctor, right? Taking medication and eating healthier and doing physical. We need to make sure that is part of our routine. And there are
Right.
ways that,
The eating healthy especially.
Absolutely.
Because my husband's from the islands. He says, I don't understand this. You can get yourself a piece of fish and get yourself some vegetables and steam it and eat it.
Right.
But
I mean, look at the price.
habit.
Look at the price of eggs right now, right? And so, how do we ensure that people are eating healthy, eating their protein, and eating the meals that they want, right? And this isn't just about folks who are low income. We're talking about everyone that's
Right.
impacted
Right.
now, right?
Right.
And see, these are policies that are affecting all of us and will ultimately affect our health, right? So, I do think we have to make personal decisions about what we need to do to be healthy. We have to really make it personal, all right? And then we also need to make sure we're educated about what our diseases are, what our family history, right? How many people are having conversations about, well, I think Uncle was showing up like he was talking to himself. Was everything okay?
So
who has
you mean we
diabetes?
gotta actually talk about the
We gotta
secrets
talk
in our
about
family?
the secrets in our
Right.
family.
Oh,
Absolutely.
okay.
We need to understand what is in our family history. Cancer rates are really high. And now we're seeing cancer rates higher among 40 and 30-year-old people.
Yeah, especially the breast cancer rates I'm hearing as well.
Colorectal,
Right.
Oh my
prostate
God.
cancer as well. We have our work cut out for us.
Well, I think Dr. Easterling's a fantastic doctor. 'Cause I've noticed two things about you. You're a very good listener. And you've got a good bedside manner, So thank you so much for joining us on this episode, talking about health disparities and inequities. It's been really informing and unsettling
Yes.
at the same time.
We unsettle pretty well here.
Yeah, do we?
Yeah.
Really good at unsettling.
And we will see you next time on Brooklyn Savvy.